Hi to everybody. My name is Rudin Dome, professor of anesthesiology and intensive care medicine, University of Medicine, Tirana, Albania. My topic for today will be how to improve brain oxygenation in ICU. Many thanks. Thank you very much to Professor Dragan Milosevic for this kind invitation in this prestigious organization in the fourth International Congress of Anesthesia in Intensive Care Medicine. Regarding disclosure, nothing to declare regarding my topic for today, so we can proceed with an original case happened admitted to our hospital in June 2025. We are the unique stroke unit in Albania. So, a 62 years old female was found collapsed in the morning in her home, and she reported severe headache and neck pain accompanied by involuntary defecation, likely secondary to an epileptic seizure. Emergency medical services go to her home and transferred her to infectious emergency department. Because they considered like a severe dehydration and suspected gastroenteritis. After that, in the ward, the patient again suffered from loss of consciousness and another episode of seizures. So she was transferred to perform or to do a CT scan. Uh, Mainly related to the situation and, of course, to the persistent severe headache that he was suffering from. CT scan revealed subarachnoid bleeding, and after that, she was transferred to stroke ICU. In her medical history, her relatives told us about rheumatoid arthritis with severe joint deformities and fixed posture, trophic ulcer in lower limb, left lower limb, but with unknown medical histories like diabetes or hypertension under aspirin 100 milligram a day, and she had in the past left eye enucleation due to arthritis-related complications, as her relatives told us. In the neurological examinations, she was somnolent. She can follow two or three, let's say, simple commands with right side motor deficits with minimal neck rigidity, diminished reflexes bilaterally, but pathologic signs like Hoffmann or Zolima or Babinski were not accessible due to deformities. The patient has in AHEG T-wave inversion and a little bit increase in troponin levels. That it's very common in the patient with or suffering from subarachnoid bleeding. And in the CT scan, the patient was fissure 4, so with the blood in the ventricles and neurovascular team decided to make an embolization of aneurysm of anterior communicans artery in the brain under general anesthesia. After this procedure, the patient was again transferred in our ICU. These are CT scans, original CT scans from the patient. You can see here the blood in the ventricle, so it's fissure 4. It's very advanced, or the more advanced form in subarachnoid bleeding from the point of view of imaging examination. And after that, the patient was transferred in the stroke lab in order to perform the embolization, which was very successful. You can see here near the arrow, the vessel after the embolization, yeah, like here. And these are original view from the lab, which you can see the vessels that it's already coiled or embolized by inserting the coil, some coils there inside. Um, After that, the patient was transferred in ICU, but after we monitored cerebral oximetry, of course, vasospasm was ruled out by transcranial ultrasound that we can perform day after day. We can see that the blood oxygenation, the blood oximeter was very low. Even let's say the hemodynamic status was okay. So we performed a cardiac echography that revealed a normal function without dilatation of inferior vena cava. This is normal function. And after that, we decided in that moment that probably we have to increase a little bit the cardiac output by using Dopotrex, dobutamine, by 5 microgram per kilo in a minute to optimize the hemoglobin level over 10 gram per deciliter and to maintain partial pressure of oxygen over 100 millimeter mercury scale in order to perform or to have better oxygenation in the brain. Of course, there was no vasospasm verified in this patient, and these three therapeutic measures that we performed have improved brain oxygenation, as you can see in these original views. So the cardiac output was 0.44 and the brain oxygenation was 62, 59 left and right instead of 24 and 46 and 32. So the brain oxygenation was improved in this patient, and the patient was discharged in other hospital for physiotherapy and for further treatment. This case was very demonstrative, and I want to give an example how to treat that kind of patient and how to improve the brain oxygenation. But of course, if we can take a look on the literature, we can see that there are many different issues to deal with because our brain it's only 2% of our body weight, but uses approximately 20% of oxygen. In this paper published in 2025, Fake or Real Hypoxia, a Brain Dilemma, it's a very interesting one, a very recent paper, an editorial one that summarized the facts regarding consensus documents and guidelines. And consensus documents and guidelines suggest use of brain tissue oxygenation, so partial brain tissue oxygenation and continuous metabolic monitoring, and the ratio between lactate and pyruvate during microdialysis tools evaluation or use in ICU. And of course, it's very logical that a low partial pressure of brain tissue oxygenation with a higher ratio of lactate and pyruvate are associated to poor neurological outcome and increased mortality. This paper is very interesting, published in 2022 in Intensive Care Medicine. The authors, very distinguished in this topic, propose some target values, and you can see that ICP must be normal, must be desirable or critical. So we must maintain an ICP from 18 to 22, or cerebral perfusion pressure from 60 to 80, or partial pressure of brain tissue oxygenation around 20-25, and the lactate pyruvate ratio less than 25. That will be our goals in order to better treat the patient and to enhance their recovery and to improve patient prognosis. Another interesting concept is ICP dose. What does it mean? What does it mean that we can have an ICP that would be approximately in the higher levels of normal value, for example, in 20, 21, but if they can be in a prolonged time, perhaps the damage in the brain would be more significant that in a moment an acute increase, but in very short time. This paper, published in 2022 in Intensive Care Medicine, let's say, distinguish or save brings us four forms. Normal ICP, but deterioration in partial pressure of brain oxygenation, increased ICP, but partial pressure of brain oxygenation, normal value. Both of those are deteriorate, or both of them are normal. If we have an ICP normal, so we have, and the partial pressure of oxygenation is low, we can have some issues with our ventilator, and we have to increase our CPP. We have to increase our FiO2 in order to improve the PaO2 partial pressure, arterial partial pressure of oxygen, more than 120 mercury scale. But we have normal partial pressure of brain tissue, oxygenation, or brain oxygenation within normal values. But we have increased ICP. We have to, let's say, to fight against the raise of ICP and to normalize intracranial pressure in that patient. And instead, in the situation that we have both of them deteriorating during the patient's course, so we have to deal with both issues in the same time. This is very important diagram and slide that I'm very fond of, and I used to tell everybody regarding this topic, that a neurologic patient, so brain oxygenation, it's not like oxygenation of heart or another organ in our body, but it's more complicated than this, because the cascade of oxygen from inspiration till mitochondria is a little bit different in the brain, like in the other organs. And convective oxygen delivery and diffuse oxygen delivery are two factors that are very important. The mental bundle for minimizing cerebral hypoxia in severe traumatic brain injury was a paper published in Critical Care in 2023 by Godi and the others. And we can see here that if the partial pressure is, let's say, 75 mercury scale in mitochondria, they can go only 1.5. But it's below than this. We can less than this value can go in mitochondria. So we tend to have a partial pressure of oxygen in order to improve brain oxygenation. We tend to have more than 75, rather than more than 100, or between 120 and 150. This paper, published in this Intensive Care Medicine in 2023, summarized all the things that we have to do. So, neuromonitoring, what kind of monitoring? For example, Jack bulb or cerebral oximetry, or invasive monitoring, in order to have some values regarding the saturation in jugular vein bulb, or partial pressure of brain tissue oxygenation. And all of this we can translate in, let's say, our therapeutic measures in order to maintain a normal mean arterial pressure. So normal, does it mean from 80 to 90 mercury scale, or to decrease ICP, or to optimize hemoglobin level, to maintain CO2 within normal values, not hypocapnia and vasoconstriction, and further ischemia, and not hypercapnia and vasodilatation, and increase of, as a result, an increase of intracranial pressure. So the monitoring and the treatment of this patient are very special, because, as I told you in our the first slides, there are some correlations between the central nervous system and the heart, and we must take in consideration both organs because, as ICU physicians, as anesthesiologists, also because this is the same diploma in Albania, so the ICU is running from the anesthesiologist. So we have to take care about all the body, not only for the lung, not only for the kidney, not only for the heart or brain, but with all of this, and of course, to take in consideration the relationship between heart and brain. And in this paper published in European Journal of Anesthesiology and Intensive Care Medicine in 2023, we can see eight fundamental rules between the so-called crosswalking between heart and brain. There are phenomena that are going, for example, hypertension or pulmonary edema, a neurogenic one, or everything, or hypotension by myocardial infarction that can directly impact brain oxygenation and brain function, especially in the patients that are suffering from stroke and so far. This paper is a very interesting one, published in Critical Care 2023, the mantle bundle. Let's say all the things that we do in our practice. So to maintain cerebral perfusion pressure or partial pressure of brain tissue oxygenation, or to avoid as much as possible hypotension, or to maintain normal glycemia, or normal levels of glucose and nutrition, and to have, this is very important, to have a PaO2, let's say around 100 to 120. There are some paper that goes approximately to 150. And of course, to reduce temperature, to optimize hemoglobin and metabolism, that are the situation that can improve the patient prognosis, because we are preventing all the secondary damages in this kind of this kind of disease, this kind of conditions. So in stroke unit patient. Coming to the end, we can memorize that we must have a normal PCO2. We must have a mean arterial pressure between these values to optimize cardiac output, even to increase a little bit, to increase as we've done in our case, to optimize hemoglobin, oxygen saturation, and of course, very important is to decrease the metabolic rate of cerebral oxygen, to decrease the need of the brain for oxygen. And to do this, we must deal with temperature, with pain and anxiety, with excessive muscle activity, with hypothermia, sedation, and anesthesia. And after this, we can say that taking home messages would be mean arterial pressure 80 till 90 mercury scale, PaO2 more than 100, optimized or a little bit increase of cardiac output, optimized hemoglobin around 10 or more gram per deciliter to reduce consume. So adequate treatment of pain, temperature, agitation, and seizures, adequate monitoring, clinical imaging, monitoring of ICP and transcranial ultrasounds, specific neuromonitoring like ECG and cerebral oxygenation with modern tools that we have in our hospitals, and of course individualize patient treatment because this is very important, and one size doesn't fit all. We have or we must know this in our ICUs in order to adequately treat the patient and to improve their prognosis. Thank you very much. I'm open to have the questions and to give my best answering your questions. Thank you very much.